Top Med Talk.
Well, hello and welcome back to Top Med Talk. We're here in San Francisco for the annual meeting of the American Society of Anesthesiologists, Anesthesiology 2023. Now, I'm your host, Desiree Chappell, and I'm joined by my co-hosts, Monty, Mythen, and Ludbrook. Hello, gentlemen. How you doing?
Great to be here, Desiree.
Yeah. Fantastic to see you all again.
Good. Monty, 5 years we were here in San Francisco for ASA.
Yeah, it wasn't our first ASA.
No, it wasn't.
But a very memorable one.
It was. It was our first time having kind of the show
We
and
had
doing
our own
fun stuff.
booth, and look how it's expanded.
I know. So we want to thank the American Society of Anesthesiologists for supporting us to be here this year and giving us this absolutely gorgeous booth and this setup. We could not do this without their support and the support of our sponsors, right, Monty?
Yeah, very generous support from all of our sponsors, including Edwards Life Sciences, Medtronic, GE, and so on.
Yeah, so on. Thank you so much.
That enables the fact that it's all free,
That's right.
Open access medical education.
Yeah, so Top Med Talk, perioperative podcast that we put out to the world and keep it completely free. And again, we could not do that without the supporters and without listeners. Thank you so much for tuning in every week and listening and joining in the very important conversations that we have. So thank you. So it's been a fantastic meeting so far. We're kind of just getting kicked off. Per the usual, having really wonderful guests to sit down with us to have great conversations about everything that's happening in anesthesia, emerging technologies that have been around for a while but are still being refined. Our next guest is Dr. Manny Vindhya, who is joining us from Provation. Manny, thank you so much for joining us.
Well, thanks for having me.
I was trying to say, now how am I going to introduce him? Do I want to say first you're the CMO of Provation, correct?
That's correct. iProcedures and the Provation iPro.
That's right. And you founded iProcedures.
That is correct.
Yes.
Yes.
And you also are a practicing cardiac anesthesiologist, correct?
That is correct. I'm in Tampa, Florida.
Can you tell us a little bit more about yourself, where iProcedures came from, and a little bit about the concept of all of that?
Yes. So if you go back about a decade or so, where everything was on paper, most of it was on paper. And we saw a niche in anesthesia where we could actually convert this space digitally. And we founded iProcedures at the time, which is the AIM solution.
Yes.
But we wanted to incorporate mobility into this one.
Yeah. So I'm going to stop you for 2 seconds because you said AIMS, and I'm not for sure if everybody knows what AIMS means. AIMS.
Anesthesia Information Management System.
Okay.
The space is so unique that it requires its own EMR or EPR, whatever space you're in.
A lot of abbreviations there for our global listeners. Electronic medical
patient record, or electronic health record, or electronic medical record.
Gotcha.
Same thing depending on the space that you're in. And it is so unique that it required its own electronic medical record for anesthesia, which is the Anesthesia Information Management System.
Yeah.
It's a complex space with complex players in a stressful environment taking care of a patient. And documentation should be the last thing people should be worried about. And so we came up with a solution in this space, and we kept on improving it, and made it the first mobile solution in the world.
Fantastic. I know I can remember doing the paper charting, and actually there's still quite a lot of people who are doing that, right?
That is correct.
Yeah, absolutely.
It's probably the dominant technology in the world still.
Paper charting. It is.
Yeah,
it
do you call it seagulls in this part of the world, doing the little seagulls for the systolic blood pressure across the paper chart?
Birds of flight. Yeah.
Somehow they're very parallel.
Yeah. Yes, they are. Railroad tracks, as we like to call them. That's correct. Manny, so people have been using paper for a long time and realize that there's a better way to do this. One of the things, we've all seen emerging electronic medical records and different ways to do things. Tell us just quickly about iPro and how that is different and specific in the anesthesia space.
That's correct. So if you look at the space itself, just digitizing an anesthetic record is not good enough, but that's a good start.
Yeah.
So if you look at the US space itself, almost everybody has incorporated an electronic medical record in anesthesia already. I believe it's just a start. Mm-hmm. But if you look at the number of cases that are done outside the operating room, non-operating room anesthesia, we are growing there as a specialty. That's about 40%, 30 to 40%. Absolutely. So this old notion that we'll design an anesthesia information management system for the operating room is old and obsolete. It has to be mobile, it has to be agile, and it should be incorporated anywhere in the hospital. So that's where the mobility comes in. And that's how we started off in this space here.
Talk to us a little bit about how the AI is working within your system. And I really next then want to talk about how all this is going to make our lives better. I'm going to just say as a anesthetist, anesthesiologist, anesthesia providers in the OR.
It's funny because we are medically so advanced in anesthesia, in medicine itself, but we're the last adapters of technology in medicine. And it so happens that when the AI came out, medicine happens to be the first one to adapt AI. This happened exactly about a year ago, November. So it's catching on fire. There's a lot of buzzwords going on, maybe replaces. All of those are, hype at this time, but it actually can augment in what we're doing. So if having a digital anesthetic record base will really help incorporate AI on top of it. It is actually a big blessing because you don't have to redo anything. You just have to layer on top of it. Once again, lots of abbreviations like LLMs, large language models, in voice activation and voice models out there. So I think AI is going to help augment what we're doing, both on the user interface side and also on the data side in the back end. And that we're just getting started in this space.
Yeah. Monty, did you have a question?
Yeah, Manny, can you give us an example of how you think that might play out, or if it's played out already?
It is in primary care space already. Okay. So the notion that we have to open a computer and start documenting is going to be obsolete. You can have a conversation with the patient and the documentation could be a byproduct of it.
Yes.
So that obviously is very native for a primary care space. But can we take some elements of that one into AIM space for documentation? And more importantly, us as perioperative physicians, can we incorporate this technology into daily clinical care? In other words, just getting the history and physical or peri-op journey of a patient without actually cleaning through records and records of their past medical history, past surgical history, their labs as a trend. That should be conversational within electronic medical record. So I see a step where the UI becomes much more sleeker, easier, uniform. But the bigger play is actually the data and how you can actually have a conversation with the data in terms of patient care.
So you should be able to go into a chart and type that you want to know someone's labs or something like that and say, I just want to know what their potassium was.
What's this type thing? We've just heard we can drop that.
Yes, we should take it to the next level where you should have a conversational analytics conversation with the data itself.
I'm so ingrained into everything as a type. I'm having a hard time making that connection. So how do you feel that, putting AI into our practice, how do we get anesthesiologists, CRNAs, everyone in this space to adopt this?
So we're always afraid that something going to replace us, or number one and two, that the machine doesn't have to tell us how to practice medicine. That's not the notion here. It is here to help us practice better, make us quicker, faster decisions quickly. No technology is going to ever replace a physician or a clinician, but it's going to make it more safer, easier. Mm-hmm. And in this environment where we have shortage of anesthetists around the world, if you look at, we have this notion of locums and a revolving door of providers coming through. They don't have to learn a new EMR or electronic medical records. So it should be easier. That's half the stress when you start a new job.
Sure, absolutely.
So if you can take that away by making it agnostic, where you can actually have a conversation, that would definitely help. So when you put these conveniences ahead in front, not as a replacement, I think that's going to help adapt. The anesthesia providers adapt this technology.
It should be as easy as picking up, the new cell phones that you can just start using the minute you take it out of the box. That's pretty much, right?
That is correct.
Guy, how does this technology?
Manny, we go back a long way, actually, and iProcedures, I've actually used it. So, I guess that speaks to the fact that the interactivity is not too complicated, because you can occasionally teach an old dog new tricks.
So if Guy can use it, then that means
ask the people that program my phone. But seriously, distraction in the operating room is not a good thing. Whether it's charting the paper seagulls or whether it's having to type stuff, it's not perfect. Your approach, there isn't a lot of typing. The interactivity actually works okay and works fluently. Is that right? And I mean, the future for that in terms of voice interaction or second guessing or thinking ahead is really quite exciting.
That is correct. And I think we should even think one step ahead where we're actually not even interacting with the EMR. Maybe a headset like this where you're saying 10 o'clock propofol, 10:35 rocuronium, where it's actually documenting by itself. So use what the technology is there to make our lives much more easier and focus on the patient. Documentation should be a byproduct of clinical care.
Oh, yeah. That is a great way to think of that. Yes. Absolutely. Vinny, how do you think this, technology is really going to help us in the OR every day and help us when we go home to not have to worry about what we're doing?
So we are lucky or unlucky. We're living through the once in a lifetime pandemic. And that has actually created an acute shortage of workforce, not on all specialties, at every level. So, and on top of it, the concept of, it's a good thing, I guess, it's a work-life balance. So the combination of shortage of workforce along with the work-life balance approach since the pandemic has created acute shortage in this space. And now that we have this locums as almost like a reality of life in anesthesia, the last thing you want these locums to come in is worry about documentation, learning a new system. The two parts of where we're always stressed out in anesthesia, besides clinical care, is I need to catch up with charting. I need to finish my charting. If you take away certain aspects of this, it actually makes a burnout. There's many, many factors for burnout. Obviously, this is not just the only one, but it actually has one of these factors will definitely help.
And that's been a big transition in my recently finished career. The stressor used to be the patient's condition, difficult airway, difficult access, difficult lines, complex pathology. It's now kind of switched to, can I get this anesthetic machine to work?
Yes.
And how do I prescribe something? And how do I find the results? Which is a very interesting transition. It's kind of like the stress levels have shifted. I don't know if that's like that in your world.
Yeah, look, I think back to when we adopted an anesthesia electronic record early on, and I sort of drove that in because I could see the merits and change. There was huge pushback.
Yeah.
And then after a while, one day it broke down and all hell broke loose because no one could now do without it. So they had to learn that, in fact, this becomes indispensable and an enormous aid to them. But it was sort of an experience that they had to find their way there. And now if it goes down, no one's happy. So, the proof of the pudding's in the eating, and people can learn to use it and see the benefits, and they're outstanding. And clearly, as you say, as that evolves and we become perhaps less afraid of AI, it's only going to help us more.
That's correct. It's an extension of our toolbox, knowledge toolbox. It's not a replacement. It's only here to augment us.
Because there was historically some degree of resistance to standardization. We've sort of accepted it most other places. You rent a car around the world now, and the bits are usually in the same place and the things work the same way, because otherwise it's very, very dangerous. Whereas we seem to somehow the world we worked in has resisted some of that standardization. Is that changing?
So standardization, as the guy said, it's hard to change the work habits they use. If you look at the adoption of electronic medical records, for example, people try to replicate their traditional workflows into an electronic way of doing things. That's not true digitization. And that's a resistance to standardization. But as you see more and more, the newer generation coming in, and more you adapt the electronic medical records, standardization is slowly creeping in. That actually helps in a lot of ways, driving protocols, both pre-op protocols, intra-op protocols, and post-op protocols, and creating some standard of care for a given pathology.
And is decision support increasingly accepted?
Got to be careful how we phrase that one.
It's true. That's a very, very important point.
It's CDS, clinical decision support, is also seen as a mini threat, in terms of replacement. But the right phraseology would be clinical decision aid, even though it's support. Doing the same thing. So
is the threat that the thing might make me better? Is that what?
The threat is the thing might replace me, but that's not true.
No, never.
But then, is it about presenting us with options? I mean, we're still in the decision point. We're still the decision makers here. But in terms of decision support, or the word we're going to use, is it putting in front of us important information that helps us filter out the background, consolidate the information, curate the information, and put it in front of us so we, at the end of the day, are better placed? Is that how it is?
That is correct. So if you look at how anesthesia is compared to flying, and anesthesiologists as pilots, there's so much technology, so much noise around. You need to filter down, so give choices. So the pilot, in this case, the anesthesiologist and the clinician, can actually make the right choices, safer choices.
Yeah.
So I think clinical decision support and clinical decision aid would definitely give those options to the anesthesiologist, which is not widely used at this time. But I see that as the next step.
And automation, because we've allowed some degree of automation, semi-closed loops or closed loops. Many of us have had low-flow anesthesia enabled by the anesthetic machine for a long time. Some people were quite stressed by it to begin with and thought it was going to take our job away, and now it happens smoothly in the background, and we say, great.
That's correct. And this automation has to be tagged into the electronic medical record in terms of data flowing. And who would have thought about 10 years ago what Desiree has the impact that it does, right? Our nitrous oxide.
Yeah.
So if you look at, we're constantly evolving, both in technology. The goal is to adapt to it. And we have global impact on global weather right now with the medical gases. So all of this will play a role. Yeah.
Manny, we're coming to the end here and wrapping up. One of the main questions that I have is, I think you said it. I mean, AI, the conversation is just so rapidly evolving just within the last year. Technology, everything in our space, we feel is starting to, really go quickly. Where do you see this type of AIMS and AI, really integrating into the anesthesia world over the next couple of years?
So the first step is digitization. We are there already. The second step is slowly adapting into the AI. While we ourselves in our specialty are constantly evolving, we have new monitors, therapeutic monitors, constant, and new therapeutics that are being engaged. And if you look at the surgical side of robotics being engaged, so all of these have to be integrated at some point. Digitization is a basic step, and adapting one by one of these technologies and incorporating into the AIMS would be the next step.
I always love having a conversation with you and hearing what's at the forefront in this space, because it is very, very exciting. So hopefully we can talk to you next year and hear more about where we are a year later. And good luck to you with
Maybe
everything.
It'll be AI enabled.
It will be. Thank you so much for taking the time out of what I know is a very busy schedule here at ASA. We really appreciate it so much. So thanks again, Manny.
Thank you all for having me.
And thank you so much for listening to Top Med Talk. You can find us at topmedtalk.com. We're going to be streaming over the next several days. Check us out there. The schedule is a little loose, so just stick with us. We'll be there. You can also find us on social media, Twitter. X, LinkedIn, Facebook. We are there. Thanks again for listening, guys. Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.